Today, my guest is Dr. Craig Foster. He's a nationally and internationally well-known plastic surgeon from Manhattan. He has a practice on Park Avenue. And Dr. Foster is an old friend of mine. I've known him for 30 years. And I'm excited to have him as a guest on the Beauty Doc Today podcast. And we're going to discuss new trends and how they fit into the paradigm of treating cosmetic patients. And I really am excited to get his thoughts about, things that where people are, there's always these trends that come and go. And I like to hear his thoughts about them since he's been around a little while, as have I. I'm in the same category. So we're going to start. First of all, before we begin, I do have to introduce him a little more thoroughly because he is trained as a general plastic surgeon, otolaryngologist, and dentist. He's covered the entire waterfront of the face from top to bottom. And all those particular areas of training has added to his expertise and ability to analyze a face and treat the patient in a comprehensive way. So, Dr. Foster, I'm going to speak to you as Greg.
Thank you, Joe.
And today I'd like to talk about, what your thoughts are about current trends in facelifting, for instance. I know a lot of people are touting the deep plane facelift as being the end all and be all, and I'd like to hear what your thoughts are and what your preference is based on your experience.
Well, yes, I mean the deep plane is recently got much more play in facelift circles. However, the basic and fundamental anatomy of the human face, in terms of its relevance for facelift surgery, was more or less established in 1969 by Tord Skoog, and it all revolves around the so-called deeper layer in the face called the SMAS, which is an acronym, SMAS, for superficial musculo-aponeurotic system.
That's a mouthful for the average listener, because this is gauged to the average listener, not to the medical community.
Right. Well, an average listener or a potential patient may get a consult, and your doctor may talk about the SMAS, which is the layer that's assumed importance really since the 70s. And most modern, basically all modern facelift techniques, to a certain extent, revolve around what is to be done with that layer. How is it to be approached? And what are you doing with it? So you can either pay attention to the SMAS layer from superficially, or you can go underneath it, so-called deep plane. Mm-hmm. So there is a controversy, I guess you might say, about what is the best way to approach and to deal with the SMAS. A lot of these questions were answered by a so-called twin study that was done several years ago, where they took 3 sets of identical twins and did different procedures on them. Different approaches, superficially, on top of the SMAS, underneath the SMAS. They did deep planes, they did so-called subperiosteal phase. They did a panoply of different approaches. They had an uninterested observer grade or try to detect which procedure had been used 6 months later. Once everything had healed, there's no difference in the outcome of the facelift procedure, whether or not you're on top of the SMAS or underneath the SMAS. The important thing was, as long as something was done with the SMAS layer, that gave the best and the longest lasting results. So I think what it boils down to for most of us is that however you choose to deal with the SMAS layer is personal preference, what you feel most comfortable with. Whether you approach this the SMAS on top and do a SMASectomy, a lateral SMASectomy, just a SMAS dissection, or application, your results will be comparable with or similar to a subSMAS or so-called deep plane. The reason many of us, I do not in myself use a deep plane approach, only because the deep plane approach, I believe, brings the facial nerve, which is the motor nerve that runs all the muscles in the face, into a little more peril. I mean, you're in the plane, or you're in the level of the face that contains the facial nerve, and I think it's a little riskier in that it does expose the facial nerve to more potential damage.
Mm-hmm.
So personally, I use a lateral SMASectomy and plication procedure, and I think time has shown that those procedures that are repeatable and deal with the SMAS layer give the best results, whether you approach it from superficially or deep.
So, but there are those advocates of deep plane who believe that if you do the deep plane, it lasts longer, you get a more lasting result, and maybe you can achieve things, say like lifting the cheek fat up higher, or something like that, to a greater extent. But having said that, I think I appreciate what you're saying, because if you go in the deep plane, there is a risk of a facial nerve injury, and that brings me to the next question. Do you think that people in New York City, is where you practice, are willing to have this procedure done at a greater risk than people say on the West Coast? Do you think there's a difference between the two?
Do I think the patient population in New York is somehow different than the patient population in LA?
Yeah.
I mean, I think
in terms of the tolerance, yeah.
Well, I do think
risk tolerance.
My feeling is, generally speaking, that the northeastern part of the United States, the patient population is more conservative. Now, in terms of accepting risk, it's all about how it's presented to the patient.
Mm-hmm.
So it really just depends on how the doctor is saying what he's saying. And even though on the face of it, the facial nerve is more at risk in deep plane procedures, I'm not so sure it's been shown to be statistically different. In other words, are there
longevity?
Are there more facial nerve injuries in deep plane as opposed to superficial? Also, I'm not aware of any study that has shown that a deep plane facelift lasts longer than any other technique that's used. It'd be very difficult to show that. The only thing you could do is do a deep plane on one side of the face and a SMASectomy or application on the other side of the face.
Well, that's where I see the flaw of that twin study that you were referring to. Is they looked at 6-month results, so we didn't see the results say out in 5 years to see, or 3 to 5 years to see if there was recurrent banding in the neck or sagging in the face, and I don't have a leaning either way. I'm just saying I'm very curious how you view it, and I now have a understanding of that, and I do respect that. It's safety first for the patient, and ultimately it may not make a difference. And also, you're undermining tissues that in planes that are normally not undermined, and you kind of undoing, in a sense, natural adhesions that may not be that beneficial.
Right. I mean, I think virtually every modern facelift technique calls for disruption of those particular facial ligaments in order to allow more mobilization of the tissue that you're trying to mobilize.
Mm-hmm.
Fundamentally, a facelift operation is an anti-gravity operation. So you're trying to mobilize tissues and reposition them in a vertically, in a more vertical position. So without releasing those facial ligaments, it would be very difficult to actually reposition these tissues and have them stay in that position for any length of time. In terms of banding in the neck, there's fundamentally very little difference in the dissection in a deep plane in the neck, as opposed to any of these other operations. It's all about, well, lifting up the lateral border of the platysma, and then how far do you go in terms of undermining it. And you're doing basically the same thing with almost every procedure. The real differences in deep plane occur in the cheek.
Well, there's a lot of people who, have focused on the neck in terms of below the platysmal muscle, which is the neck muscle. Again, I think there's greater risks once you go below the platysma to dissect deep there, or even manipulate the salivary glands, which are over here. So what are your thoughts about doing that? For instance, there are people who routinely do salivary gland reduction in order to get more of a extreme contour of the neck.
It's true that one of the persistent problems in facelift surgery, and as it pertains to the neck, is a large or low position of the salivary glands, so-called submandibular glands. And, many procedures have been promoted to reposition, tighten, or actually reduce the salivary glands. My personal opinion is that's maybe just a bridge too far. The salivary gland, and certainly that location in the neck, has a lot of important things going on right around it. The marginal mandibular nerve, which is the nerve that runs the lower lip, actually traverses right over the gland. There are major arteries and veins in that area. So even though some surgeons are comfortable attacking the gland and actually doing a reduction, which I think is the only particular technique that actually works to alter that area. For me, as I say, it's just like a little bridge too far, a little too risky. There's too many important things going on in that little patch of real estate that makes me want to attack.
Okay. Well, I'm just throwing it out to you because there's a lot of hype about different procedures, and I think that it's easy to jump on the bandwagon because the public may be pushing or heard about these procedures and don't recognize the associated risk when they visit their plastic surgeons, and they should know.
It's a case of a tail wagging the dog. I mean, the surgeon has to decide for himself what he's most comfortable doing, what he feels his expertise or his clinical judgment or his particular surgical skills will lead him to produce the best and the safest result for the patient. So if that includes reducing the salivary gland, and they're very competent doing it, and they've done it, and they feel comfortable doing it, then more power to them. The problem with jumping on the bandwagon, and this is usually a problem for, our younger colleagues who go to meetings and hear these talks about, these procedures where we're dealing with this problem with the neck, and then think they can go back and start doing it. That may be fraught with a little bit too much risk, in my view. I think mistakes happen in those sort of circumstances. So it's easy to be swayed, both the public and the surgeon themselves. You just have to be careful.
Yeah.
This is, in essence, this is a totally unnecessary operation. Nobody needs this operation. So the idea is to try to deliver the best product in the safest possible way.
I got it. Yeah. Now I'm going to switch subjects a little bit, because I know that you're an expert in rhinoplasty, and you've operated on people I know, and you've done an outstanding job. So why, in general, rhinoplasty is fraught with complications as well, potential complications. The recurrence of rhinoplasty surgery, nose surgery, by the way, I'm using medical terminology, cosmetic nose surgery, which is not purely cosmetic, by the way. As you know, it has to also have a component of functionality, and that's where you come into play. In particular, that's why I'm particularly interested in your practice, because you have ear, nose, and throat training as well as general plastic surgery training, and so you have a perspective from both fields, and I really feel that when it comes to functional improvement, I think the ear, nose, and throat doctor is typically more attuned to breathing issues than just pure aesthetic issues. And that's why I think your training is so important, because you have that dual training. And so where is it that, first of all, how do you feel your ear, nose, and throat training has reflected on your general plastic nasal surgery training in terms of your understanding of the nose and the aesthetics and the limitations?
Well, I mean, certainly ear, nose, and throat physicians in training get much more emphasis on nasal function than the general plastic surgery trainees do. So they understand more about the septum, the turbinates, so-called nasal valves. These are all technical, I'm sure, terms that may be difficult for the public to understand, but they all figure in performance of a rhinoplasty operation. So function and cosmesis go hand in hand. I do a lot of secondary rhinoplasties, which are rhinoplasties or nasal procedures that have been done before, and for one reason or another, the patient is unsatisfied with the outcome, and they seek a secondary rhinoplasty.
I'm gonna interrupt you there. Is it typically for a cosmetic redo, or is it due to the lack of the ability to breathe after they've had the rhinoplasty done? Is there a 50-50 split there, or is it somehow?
I would say in close to 100% of the cases, both issues come to the fore. In other words, the typical secondary rhinoplasty patient doesn't like the way their nose looks, and they don't like the way their nose works. So in probably 90% of the cases, it's really both things that they're complaining about. And I usually will counsel them that many times they'll have to make a choice or a decision about what's more important to them, the function of their nose or the aesthetics of their nose. Because in reality, the cosmetic operation decreases function. Virtually 100% of the time, cosmetic nasal surgery will alter function. Now, does it alter it enough for it to be a problem? Blessedly, no, not usually. But if you think about what you're doing when you do a cosmetic rhinoplasty, you're usually making the nose smaller. You're making it narrower. You're removing tissues, cartilage tissues from the tip of the nose that have an important function in breathing. So that if you asked your sort of average rhinoplasty patient who was otherwise satisfied with the way their nose looks, well, what do you think about the way your nose breathes? They'll almost always say, well, maybe I breathe a little bit less than I used to, but I don't care. My nose looks better.
Oh.
So, when you're approaching a secondary rhinoplasty patient, I'll oftentimes tell them, look, some of these circumstances you have to choose. Oh. Because some of the things that I could do to make your nose work better will make it look worse. I'm
Oh,
going to make it fatter. I'm going to
yeah.
make it bigger, the tip fatter and the
Oh, I
bridge
see.
fatter.
Yeah.
So,
Spreader grafts up
yeah,
here and stuff like
yeah,
that. So
mhm,
it widens the bridge of the nose, right?
yeah.
Mm-hmm.
Any of the things that you will do functionally certainly for a secondary rhinoplasty revolve around putting things back into the nose, rebuilding things,
Mm-hmm.
which will have an adverse effect potentially from the viewpoint of the patient in that it makes their nose bigger. So when asked to choose, the vast majority of patients go, I want my nose to look better. I'm willing to sacrifice some function as long as my nose, you correct the thing that is bothering me about the way that my nose looks. So these two things are
Interesting.
butting heads a little bit.
Oh.
There's a little bit of conflict here between the things we do cosmetically for noses and the things that we may do functionally for noses.
And do you think so do you think from the get-go, when the patient goes in for a primary rhinoplasty, primary nose job,
Yeah.
the doctor is really not discussing maybe the pros and cons, so to speak, of doing a cosmetic procedure that's going to make them look better, and how it may compromise the functionality of the nose. In other words, do you think right from the start that the functionality comes in conflict with the cosmetic aspirations of the patient?
I think it does, yes. And again, it all depends on how the consult is conducted,
Right,
what the doctor is discussing with the patient.
right.
So
Well,
many times I'll see patients that will come in and they'll say, I can't breathe out of my nose, or I have trouble breathing with my nose. And oh, by the way, I don't like the bump on my nose and my tip is too fat. And I'll do an examination, an internal examination, and I look at their septum, which is, of course, the thing that you're usually focusing on. And the septum looks pretty good. It's basically pretty straight. So I can tell them, look, I can appreciate that you have a functional issue, that you're having problems breathing, but it's not a structural problem. In other words, your septum's not crooked, your turbinates look healthy. If I do a septoplasty on you, it will make no difference.
hmm
The other thing you have to understand that is if we do a cosmetic rhinoplasty on you, you may lose some function. So that it is something that you need to be prepared for, or you need to accept as a potential outcome of cosmetic operation. On the flip side, sometimes I'll ask a patient, do you have any trouble breathing? And they'll say, no, my breathing's pretty good. And I'll look inside their nose and their septum looks like a carnival ride. I mean, it's all over the place. And
uh-huh.
I'll tell them, well, your septum is fairly significantly deviated, and I can guarantee you that if we do just a cosmetic rhinoplasty on you, I will tip you over into having more trouble breathing. You will notice it.
Oh.
So in those circumstances, I'm going to tell them, look, we need to fix the inside as well as the outside in order to get an optimal result.
And do the general plastic surgeons who do rhinoplasty, are they capable of fixing what I call the functionality? I'm not asking you to throw stones at your colleagues. I'm just asking, do they typically know how to treat the functionality? And with the nasal valves and so forth, I'm sure they can do a septoplasty, but there may be other issues at play.
Right. I think it's all a function of their training.
Yeah.
Most general plastic surgery programs, unless they affiliate in some sense with an ENT program, their residents are really not getting, I don't believe, much exposure to an in-depth or sophisticated approach to functionality of the nose.
Mm-hmm.
When I get secondary rhinoplasties, if I get them from ENT people, I'm going, there's probably not much cartilage left in that septum. They probably were in there. If I get a consult from a plastic surgeon, I'm going, oh, well, I know the septum has probably been untouched.
Oh,
And will serve as a bank for anything I need
I got
to
it.
rebuild. Yeah, to rebuild the nose.
I see.
So it's really a function mostly of training. The problem with rhinoplasty training in general across the country is, in my experience, I don't think plastic surgery residents these days get adequate training in nasal surgery.
Mm-hmm.
They rarely do any. They probably see some, but I don't think they really get adequate training, and they don't really have a good understanding. And
Of the
many
complexities.
complexities, and many of my former professors and everything. So look, you have to do 200 or 300 noses before you even understand it. before you even are trying to get predictable, repeatable results.
Okay, so that's an interesting comment, because obviously in general plastic surgery residency they're doing breasts and doing everything in between, and so it's hard to be a expert at the nose unless you get a really in-depth experience.
Yeah.
I know that you're. How about your dental training? What has that brought to your practice in terms of? I'm not saying you're doing teeth, but I've read an article of yours that you co-authored with other plastic surgeons on orthodontic surgery, in particular the chin.
Yeah.
And does your dental training has it given you insights into the perioral area in terms of what can be done, what can't be done? I'm just curious, because I think that sometimes chin implants don't do the job, and I'm just wondering whether or not, how often do you do sliding bone operations, genioplasties, to correct a chin projection?
Yeah, I think any training or any experience that you've had, it could be with ENT, it could be as an oral surgeon for that matter, always gives anybody a better understanding of what's going on in the head and the neck, because that training is usually more extensive than just the teeth.
Mm-hmm.
I haven't done a sliding genioplasty for years now, only because, in my view, chin implants solve most of the problems of the chin. And a chin implant is a reversible operation. When there's a problem with it, you just take the thing out and you're basically back to where you were. Sliding genioplasties, of course, they're an important part of orthognathic surgery, and there are many guys that do a lot of them, and they're fine. But that's a much more invasive and much more destructive, potentially, procedure. So if I had somebody that really had an orthognathic problem where a chin implant would not suffice, I will usually refer them to an oral surgeon, because it's usually not as simple.
Oral maxillofacial surgeon?
Yeah.
Okay.
An oral surgeon that does orthognathic surgery. Because if their chin is that retruded, it's never just the chin. It's everything. It's often.
It's the mandible and everything.
That's the mandible, it's the maxilla, it's the whole, it can be the whole thing. So if I have something I don't think I can safely or easily solve with a chin implant, I usually refer them out to somebody that's doing that surgery more frequently.
Do you use any onlay synthetic implants, like on the cheek, for instance, or do you rely on injectables to enhance the midface?
Well, both. The obvious advantage of an injectable is that it's not surgery. It takes a few minutes sitting in a chair. The disadvantage of it is, 6 months later or 9 months later, it's gone. Right. So it has to be repeated. Cheek implants are particularly a little twitchy, only because there are two of them. And in order to achieve symmetry, it's very difficult to do, because we as humans are not symmetrical. So there can be some underlying asymmetries that you put a cheek implant in, and they come to the fore. You see them more. Oh. Also, the positioning of the implants. While, if you're an expert and are, and you can almost always get cheek implants on, so to speak, where they're in the exact same positions bilaterally. They are certainly fundamentally more difficult than a chin implant. A chin implant is just one thing, and if you get a chin implant that's off like this, very difficult to even see it.
But it could ride up, though.
Yeah, if you get a chin implant that's off like this, now you got a problem.
Yeah.
So cheek implants are certainly more finicky. They also, I think that cheek implants masculinize feminine faces. So you have to be, you have to be careful. I think, one of the fundamental things about certainly facelift surgery is that you're not trying to make any fundamental changes in the way the patient looks. All you're trying to do is make them look like they did 10, 15 years ago. You start adding things like cheek implants, sometimes fat. Fat's another thing that's very popular right now.
Yeah.
You are making a little bit more fundamental change in the way they look, which they may or may not appreciate. So I use cheek implants. I do cheek implants. I just find them to be a little more finicky.
Okay.
Yeah.
So that's interesting because, again, that's something that's kind of passed off as something simple and insignificant almost. And yet, you're right. Well, I think there's asymmetries in the face that people don't appreciate,
Whenever you start thinking like that, you're setting yourself up to get slapped. Because there are surgeons that have complications and there are surgeons that don't operate. Yeah? So anybody that does any of this stuff is always going to run into trouble. Right. So there's no operation that's a simple thing.
Mm-hmm.
They all need to be treated with being serious about them.
Right, and approach it with caution. How about lip lifts? What's the story with lip lifts in, say, New York City? Do you think that's a popular thing? I know in LA, there are young women who are having lip lifts like it's going out of style. And I think that maybe they're buying into an aesthetic that is popular in 2020, but maybe in 2030, that aesthetic may no longer be, in fashion, and they now have to live with it. So, yes. What's your thoughts about that?
You could say the same thing about rhinoplasty. I mean, the rhinoplasties that were done in 1970 don't hold up very well.
Mm-hmm.
So, you have this rhinoplasty done. I'll get back to lips, but you have this rhinoplasty done.
The diamond nose?
You're 15 years old, 16 years old, and you got this cute little button nose. It's hard to wear that when you're 60. So, rhinoplasty is a case in point. Now, lip lifts. The unfortunate circumstance, I guess, or the reality is that there are no good things for lips. I mean, there are good things for eyelids, there are good things for noses, there are good things for faces. There are no good things for lips. So,
you don't like injectables?
I do. Simple is always best.
Okay.
Now, injectables, like anything, can work and work appropriately, but they can be overused. And certainly all of us have seen people who have had too much of whatever put into their lips. The reason I like fillers, Juvederm, any of the hyaluronic acid products, is that they're reversible. I mean, if the patient goes, "What did you do to me? I hate you," I'll say, "Well, okay, give me 5 minutes and I can make it go away."
Yeah.
The lip lifting procedures themselves, it's all about the scar. It's all about the scar. So if you're making a lip lift where you're making an incision on the lip itself, and there are some
I'm talking about a bullhorn incision.
That incision, actually, if it's done properly, is the best thing in terms of a lip lift that you can do. Now, it'll only lift the central third of your lip. It won't lift the lateral margins. So it's important to tell the patient, look, this is only going to be kind of the central third, maybe a little bit of the central half of your lip. And you have to ask them to smile, give you a good broad smile. So if they give you a good broad smile and you see gum, gum above their central incisors, you got to tell them, look, if I lift your lip, you're going to have a gummy smile.
Yeah.
You'll be able to get maybe 2 millimeters, maybe 3 millimeters out of it. The cow horn, so-called, the incision that runs across the base of the nose, should heal great if it's done well. The problem that I've seen with them is if a guy just does a straight cut across the base of the nose. I've seen them where they do a lip lift operation where they basically have just made a straight cut across the base of the nose. They haven't actually followed all these contours. What following all these contours does is it hides the scar.
Yeah.
So there's no free lunch
Mm-hmm.
If you make an incision someplace and you create a scar, it better be the best one that you can do, because the patient in the end, what they're going to be looking at is maybe my smile, I see a little bit more of my teeth. What I'm looking at is that scar.
Yeah,
and,
yeah.
and if they see it, they're going to be unhappy with it. So I do lip lifts, but
Selectively.
infrequently.
Yeah.
Selectively.
So, but what do you think about this idea? I'm just going to circle back to this idea that the aesthetic may change. How does that factor into your discussion? Do you actually? I'm always concerned telling a patient, look, it may be popular even in the eyelids. There was a time when there was deep sulcus on the upper eyelid, deep hollowing out of the upper eyelid. And Lucille Ball and the actresses of that age,
Twiggy.
And now, of course, everybody wants to look like it didn't have anything done except a little skin removed. So it's really this. It swings.
Yeah, I call it the Twiggy effect. That
Okay.
hollow look. She was so popular.
Right, Twiggy. Right, exactly.
And that for years, we were taught. We took skin, we took muscle, we excavated all the fat out of the upper lid, and you gave them this sculpted so-called upper lid. It's much worse than the lower lid. If you take too much fat out, that looks terrible in the end. So if you open up any woman's magazine and you look at all the models that are 16 years old, they're not old people. These models are all young kids, and you look at them and they've all got fullness in their upper lids. So eyelid surgery has evolved now so that I remove certainly less skin than I did. I don't remove any muscle anymore. And usually I'm not taking all that much fat out. I mean, there's some obvious fat removal that may need to be done, particularly on the inner corners of the upper lids. But certainly the way things have evolved in upper eyelid surgery is that it's much more conservative. You can always go back and take a little bit more out, but once it's gone, it's gone. Mm-hmm. And so most people do not like that sculpted, hollowed out look. It makes them look older.
Right.
And particularly with lower lids, if you've taken too much fat out of lower lids and they get this hollow look, it looks bad. It makes them look older. It's very difficult to fix.
Yeah.
I mean, there are things you can do, but it is difficult to fix. The lower lid, I think, it's a pit of vipers. Bad things happen in lower lid surgery. Mm-hmm. And the more conservative you are in lower lid surgery, the better.
Mm-hmm. Well, there's fat transfers and fat grafting that's going on. That's also trending. And
people are injecting fat everywhere.
Yeah. And that brings me really to a final question about fat. Because fat, to me, is also potentially a den of horrors, because the patient is you're grafting fat from, say, the abdomen, take abdominal fat from your belly, putting it in your face. It's very, very popular as an adjunct to facelifting or even eyelid surgery. And then if the woman, in particular women, because their hormones will potentially stimulate that fat that's now been transferred from the belly to the eyelid or the cheek, they could end up being much larger if they gain weight. And so, again, how do you balance this desire with reality, if you know what I'm saying?
Yeah. Well, the thing about fat, it's interesting to me. I mean, the thing about fat grafting theoretically makes a lot of sense, because certainly one of the things that contributes so much to the appearance of aging is the kind of the loss of that kind of juicy plumpness that you had, when you're 20. Mm-hmm. It just sort of goes away. And so the concept of trying to replace it with fat makes perfect sense. But it's an imperfect operation, obviously, as all operations are. Mm-hmm. And the problem that I've seen, and I use fat. I mean, sometimes I'll have a 70-year-old lady who wants to have a facelift. And you can pull that skin and you can pull that mass, but she needs some
Volume.
volume
Mm-hmm.
in the face.
Mm-hmm.
The problem I've had with fat injecting is, well, I mean, you can do it and it looks good, but does it hold up? So I always tell patients that the typical fat graft patient, whatever you see at 4 months or 6 months, usually is going to be permanent, but you can expect to lose a significant portion of what I put in there.
Mm-hmm.
So, I mean, you can either overcorrect the patient in anticipation of fat loss, and then they look like an idiot for 6 or 8 weeks. You know, look like a pumpkin on a fence post. Most of my patients in New York City are never going to tolerate that.
Uh-huh.
So you can put in what you think is an appropriate amount of fat to make them look good, but you know that in the vast majority of patients, you are going to lose a significant percentage of that.
Okay.
It can be particularly problematic, I believe, in lower lids. And again, it's mostly about fat survival. If you get fat survival, well, most of the time that's going to be a good thing, but some of the time it's not a good thing, because in lower lids in particular, it can look bad. It can look lumpy.
Yeah.
It can feel lumpy, and getting it out of there is no fun. I mean, you can do it technically, but it's a difficult operation.
Yeah.
So I think we're on the right path with fat. But I think it'll be something different. It'll have to do with stem cells. I mean, I think stem cells is going to be the future of not just what we do in cosmetic surgery. It's going to be the future of medicine, where we'll be using stem cells to replace hip surgery or heart surgery or any of these things. So the real future of medicine, and certainly cosmetic stuff in general, I think is going to be stem cells. So you can get stem cells from adult fat. There aren't many of them in there, but there are some. So you'll see some spectacular results with fat injecting, like under scars and things like that. And the supposition or the feeling is it's probably the stem cells in the fat that are doing most of the repair, and not the fat. Not fat's basically dead fat, dead tissue when you put it in someplace.
Oh.
So I think the real.
So you don't think the fat is actually surviving? You mean, or?
I think some of it is, and most of it isn't.
Oh.
I mean, there's a lot of different ways to treat. Everybody has a way of treating their fat. Centrifuge it and wash it and do all this stuff. I think it's pot luck. I think you inject the fat. You inject the fat into a bed, and some of it takes, and some of it doesn't. I have seen a couple of cases where more took than you wanted. And you have to go back in there and you have to recontour it. You have to take some of it out. Yeah. But the vast majority of fat patients lose, I believe, most of what you inject. Not all of it, but most.
Have you seen any difference between where you harvested the fat from and where you placed it? It changes things? In other words, is the fat from the abdominal fat better than the hip fat or the inner thigh fat? Some people say even buccal fat is different. Some people
I'm sure they're right. The fat is different in different locations, but nobody's ever shown anything, a study of some kind that says abdominal fat is better than
hip fat,
inner thigh fat or something. Mm-hmm. I think it's a matter, I think logically, it's a matter of convenience. I mean, you go to the donor site that's most convenient. Now, with a lot of fat injecting, when you're using large volumes, this is another area that's totally different really than the face. But when you're doing breast augmentation with fat injection, or you're doing butt augmentation with fat injection, now it becomes a volume issue. Most girls with small breasts don't have a lot of fat. So if you're going to do a fat transfer to a breast and you're going to put 300 cc's of fat in each breast, where are you going to get it? Mm-hmm. Now it becomes a donor site issue. And this all reminds me of the free flap craze that we all went through back in the 80s when free flaps first came about, and we were taking chunks of tissue off of different parts of the body and putting them here, thither, and yon. And then all the problems with donor sites started showing up. So, I think there's a real risk of these massive fat transfers, of there being significant donor site morbidity.
Mm-hmm. Mm-hmm. Interesting thought. Yeah, I hadn't thought of that. Okay, listen, I think we're going to wrap it, and I want to listen, Greg, Dr. Foster. I really appreciate your time, your thoughts, and your insights. You have a lot of experience, and I talk to younger surgeons and other people who aren't surgeons, and I think I'm an old guy too, so I think experience counts. And but what I'm saying is, in the end, I think we need, that's why I'm coming to ask you your opinion, because I really value your experience over 35 years, right? 35 years?
Yeah, something like that.
And
I try not to think about it.
well, I know I'm in practice 35 years myself, so, but I think that there's a lot of things to measure before you cut, as they say.
Yeah.
So,
well, experience is always hard won. You always get experience. Usually, your mistakes and your problems give you much more experience or knowledge. And I'm still making mistakes, and I'm still learning things. It's a never-ending process. So, the concept that, well, I never have any complications. Well, you obviously don't operate.
That's right.
Yeah.
That's right. Okay, thanks again, and I appreciate your time and your thoughts. So.
All right, Joel.
Bye-bye.
Thank you very much. Stay healthy.
Okay, you too. Bye-bye.